Good morning, everybody, and thank you so much for having us. I'm so happy and excited to celebrate and inform you about the work that we do out in Burnaby. Thank you, Dr. Smile, for the wonderful land acknowledgement. We also want to acknowledge that we are very lucky to be able to live and work on these sacred lands and partner with our Indigenous colleagues and families in the work that we do in Burnaby as well. So as you may have seen, we have a couple of objectives to introduce you to the Children's Services Resource Team out in Burnaby and to introduce you to this unique therapist developmental pediatric partnership that we have had there for a very long time. We want to review school-based therapy services using Burnaby as this exemplar and giving you some clinical case examples of the kind of work that we do. We also want to look back and reflect on the lessons that we have learned over these many years in a school-based therapist dev-ped partnership. And again, this is truly a celebration of my colleagues and the amazing work that they do. So sometimes, not sometimes, but quite often, when we are working in different sectors, the spaces between those sectors can feel a little bit like this. The spaces can feel vast with very few natural connections that can bridge some of these spaces that seem almost insurmountable. Sometimes these spaces exist within the healthcare sector, but oftentimes there are large gaps between the health sector and the educational sector. And we completely understand and cherish the kind of opportunities we have within Burnaby to create smaller gaps between these sectors, which often stand alone and apart. So I'm not sure how many of you cross east of Boundary Road, but we wanted to just orient you a little bit as to where Burnaby is located. It is located on the traditional unceded territories of the Squamish, Musqueam, and Tsleil-Waututh peoples. It is the geographic center of Metro Vancouver, bordered to the north by Burrard Inlet, bordered to the east by North Road and 10th Avenue, close to New Westminster, bordered to the south by the Fraser River, and bordered to the west by Boundary Road. And there it is. The population is probably going to be significantly revised with the next census, but it is quite a substantial population with a fairly steady annual growth rate. And it's a very popular place, especially now with all of the city-town planning and the Millennium Line and the Evergreen Extension. So it is well served by many SkyTrain lines and transit. It also houses Simon Fraser University. It is very culturally diverse, and I would say more than half residents have a primary language other than English or French. And I'm very curious and excited to see what the next census is going to show as to how our city is changing over time. So Burnaby School District 41 is the fourth largest school district in the province. I was just taking a look at some statistics. Surrey is, of course, number one with over 85,000 students. Vancouver is number two with 50,000 students. Coquitlam just beat us out by a little bit. They're at 35,000. And we beat out the Central Okanagan School District just maybe by 1,000 students or so. So we have quite a few students enrolled, as you can see, 27,000 students. We have 41 elementary schools and 8 secondary schools in the district with a range of district programs, which include learning assistance programs, life skills programs, pre-employment, work experience vocational programs, adult education programs, enrichment programs, and also some unique provincial resource programs, such as the amazing BC School for the Deaf. This school runs programs at South Slope Elementary for K to 7 students and at Burnaby South Secondary for grade 8 to 12 students. And it delivers services with ASL, oral, and mainstream education. It is a phenomenal place, and I'm so lucky that I've been able to be in those spaces with the amazing students and teachers there. I am very thankful to have been part of this team since I was a subspecialty resident way back in the day. I landed there, embedded myself, and never looked back. Um, this program certainly precedes my involvement by a number of years. It's been a long-standing sessional contract that Sunny Hill has had in partnership with Fraser Health. And up to 40 sessions have been allocated, which is a half day every week during the regular school schedule. It is a unique partnership within Fraser Health because, as you will hear from my colleagues, they are housed within the Fraser Health um, uh, system, and therefore it is a really wonderful physician therapist partnership that can exist through that lens. And the focus of the work, and we'll expand on this some more, is medical and developmental complexity in the student population. So how unique is this program? Well, a number of years ago, we wanted to explore this in more detail by doing literature reviews of the kind of physician educational partnerships which have been reported in the literature. And to no surprise, there are many school physician partnerships, either in the form of clinics that are specific to, say, adolescents, or a general clinic, um, or the school can call upon a physician directly in certain jurisdictions if they've formed those formal or informal partnerships. But the notion of a therapist developmental pediatrician or a therapist physician partnership is unique and, in fact, extraordinarily powerful because my colleagues are experts in complexity, and they can identify complexity within their caseload and their wait list in such a way that a question can be framed very, very clearly and can really move things along for a student in ways that perhaps another type of engagement may not be able to serve as fully. We were very proud to present this work at the Health and Wellbeing for Persons with Developmental Disabilities Conference a number of years ago to celebrate this work. So there's are probably colleagues on this call that have a lot more institutional memory than I do, but I believe that this service was traditionally intended to serve an underserved region. As large as Burnaby is, there was traditionally a lack of pediatric coverage in the area. I would say that due to multiple factors, we're probably again in a state where it is harder to get connected with a pediatrician in the community. And there are lots of factors related to that, including lack of access to a primary care provider that can certainly stall things. And the less providers there are working full time in the city, the less likelihood that a consult can be uh, attained in a reasonable and timely way for a student with developmental or behavioral concerns. We have across the world and also across the province seen an increasing complexity of patient populations within inpatient settings, but also within our schools and our communities. And our team is a testament to witness these incredible children um, um, thriving, flourishing, coming to the school system and being able to access and participate in the amazing programs there. The program is served by myself, Royal College developmental pediatrician, and whenever I am privileged to do so, I have my subspecialty residents and clinical fellows joining me in that program, which is quite, it enhances my day when I have trainees. And the services which we provide also enable referrals to additional Tier 5, 6 complex services back here at Sunny Hill Health Center and BC Children's Hospital. So we have that unique lens of being able to identify children who need a closer look by some unique services here. So the primary focus, of course, is on children with moderate to severe physical and developmental disabilities, and often the focus is on caseload students who have complex neuromotor and sensory impairments. But the scope is very diverse because it reflects the need in the district. Complexity is showing up in ways that sometimes schools can anticipate, but often they can't, and they're trying to meet the needs and the functional needs of the child in whatever way they can before they have some clarity about direction. Um, Usually, there is a school referral directly to CSRT for OT or PT opinion, which then can identify the need for when a DevPed might need to be involved. Um, and as I said, the priority is for caseload children, but we also have children on the consultation waitlist, and my colleagues will explain this in more detail for you. We do direct assessment or triage consultations for children in kindergarten to grade 12. On some occasions, we have done some school visits, or most of the time we do school visits, but on some occasions we have done some home visits when the circumstances have called for that. And that is a unique privilege that I'm able to have with my therapy team. Occasionally, we try to remove some barriers to referral to CDBC or BCAAN services, and we're very keen to work with the school to see what service assessment services can be delivered directly by the school without our direct sort of involvement as a referral source. I think COVID definitely changed the paradigm, and we had to reduce a lot of barriers. For BCAN, we know that there are less barriers to accessing a referral from a primary care provider. But there have been instances where we have had to step up and make that referral as a last resort option. On rare occasions, when the circumstances for an existing CDBC referral completely prevent a family from physically being able to make it to an appointment at Sunny Hill, we have partnered with CDBC for children who are already known to see SRT to be able to enable me to go and be able to provide that consultation at school. There have been instances, for example, parental health issues, massive transport issues, other social complexities, and we've been able to serve that need from time to time. And sometimes we have seen children who have been uh, getting transferred care between different social workers and legal guardians, or children who have had some changes in their family structure, and the school is their hub, their community, where I'm brought in to be able to um, be part of that trusting group that can also help connect this family back to a more consistent community health provider. Um, so in addition to the developmental complexity, for us, the priority for getting me involved is the significant access barriers to even a primary care provider. So sometimes on a child's school registration, a family may have mentioned a family doctor or a pediatrician once upon a time, and there are a lot of questions that are put forward by my colleagues to the family to see who is actually actively involved. And when those explorations are carried out, often the answer is there is no such primary care provider. They have retired or moved, and that pediatrician saw them 8 years ago for an entirely different concern, and there is no way that they could get back to them. A lot of families have lost their primary care providers, and the available walk-in clinics often mandate that a family logs in and tries to book a spot, a walk-in spot for a particular time of day in order to then physically show up and then maybe get seen for a referral. And if they don't have a clear letter outlining the concerns, sometimes things just fall apart and they're not able to get anywhere. Or simply put, the primary care provider has declined doing anything, even when the letter has been clear. We have had access barriers to a community pediatrician as a result. Um, even for kids with complex health needs who should have routine access to their community pediatrician for something as simple as orthotics replacements. Just getting a prescription seems like a very simple thing, but can be a very complex set of challenges that a family has to coordinate. So those are some of the simplest tasks that I do, but they often are some of the ones that can create the most stress for a family and for the therapists too, who are trying to meet the needs of these kids who come back after a summer having grown several inches and have outgrown everything. So this is just the reality of how things go. I would say there are persisting COVID-related health access imbalances, as I'm sure we all appreciate. There are still colleagues in the community who do a virtual health only consultation, and for better, for worse, they're not necessarily able to understand the big picture of what the school is experiencing, what the therapists have observed, and they're not able to serve the family in the way that they need to be served simply because of lack of information and lack of the family being able to express um, anything beyond their own experiences with their child, which can be very different than what the experiences are at school. So even though we are not structured as a comprehensive program, like the Richer program, we still deliver a lot of social pediatrics and a lot of social care. Burnaby has a very um, high number of refugees. We have a community neighborhood called Edmonds that is structured to receive refugees. There's a newcomers clinic that is well supported by nurse practitioners within walking distance of housing that is there for people who are new to Canada with a lot of psychosocial supports, and is also within walking distance of Edmonds Community School, which has a lot of wraparound programs. So that's one type of newcomer that we experience every time there is strife in the world, conflict. We can anticipate we're going to get a wave of individuals from that region that we will meet. We will hear their stories. They will empty their hearts, and we hope that we can bridge them to the next step in their journey. So in addition to refugees, which do come with some medical check-in and oversight, there are many newcomers who do not. For example, um, permanent residents, so people who fly in and they have a PR status, they may or may not have any automatic connections to healthcare provider. There are also individuals who come here on their own personal student visas, and we have had one case in particular that we've had to escalate to the MLA and to Ministry of Health because the family couldn't afford the MSP fees for their youth who had significant developmental complexity. So we get newcomers from many different streams, and it is only when you are doing this work in the community that you realize what the true barriers are and how lucky we are that we're able to reach these kids within the school. We are sometimes their only point of contact for an undetermined period of time before they can get connected to other medical services. Um, there are some children who are not eligible for multidisciplinary assessment through BCAAN or CDBC, but the school is looking for some direction and recommendations. With my involvement, I can get things cleared up about what we can, what we cannot do, we can or cannot offer through our programs, and then be able to really encourage the school to plan wisely and accordingly to meet the needs of this child within the school system to the best of their ability. I am in awe of the creativity of our educators working under significant constraints every single day. It is something to behold being in a classroom these days. Um, we encountered developmental coordination disorder, and as much work as my esteemed colleague, Dr. Michelson, and her colleagues have done about supporting the work of DCD in the community, often it can remain an orphan diagnosis, a beautiful OT assessment completed, no physician to sort of take a look at things and formalize a diagnosis or explore beyond DCD, as we call it, DCD plus. It's one NDD and it just unravels a whole bunch of other NDDs that may need to be looked at more closely. I have had the privilege of also being part of school meetings where I've attended individual education plan meetings or informed a team about a genetic disorder or a behavioral phenotype that they may not have been aware of. And one of the highlights of the year is the holiday education talk. Last year, I tried doing an AI generated quiz, and it was semi-disaster, but it was fun. And we just try to mix it up every single year. The point of the involvement is that meetings and information exchange is timely and relevant. Families provide consent for CSRT to contact them. I'm under their consent form. They provide consent for me to meet them, often at school, to have a conversation. They provide consent for the letter to flow back to themselves, any physicians in the community, and to their principal, so that that information exchange is extremely timely and can move things along relatively quickly through the school system. And because I work through the lens of the Ministry of Education designation, areas of functional need, things really do get mapped very quickly and can move forward for applications for various designations. Um, I think we have a very good sense, and I say we as the team of the kind of health concerns that can affect a child's school access and performance. And we could frame it in such a way in our documentation that really helps the school understand the situation as well. The consultation is prompt. We try not to take on a lot of investigations ourselves because of the just the lack of ability to remain in constant follow-up. But we can initiate a whole bunch of things once we know that there's going to be someone on the receiving side. We can coordinate care, and we believe that enriches the therapeutic service all in all. So these therapist, physician, and school dev ped connections are really, really important. My ability to refer children to various specialty services at BC Children's in Sunny Hill is is really such a privilege because I could actually see what's going on. You know, there was one case where a child, went to the community neurologist. They got the story from the parents that wasn't very concerning, but when we sent the video in of how the child was attempting stairs or running, and we highlighted the urgency that this was far beyond a developmental coordination disorder, it really led to further investigations, and SMA2 was identified. So, just that organic view of the child in their natural spaces and places is a powerful thing. We can bridge things back to for continuity of care. And also to my colleagues in the neuromotor program, if there's been a change in state of a child at school, I can give my colleague a heads up and say, we're noticing this. The school is noticing this. The therapists are noticing this. There's been a change. It's probably something that the family may not mention to you when they see you. However, we want you to know. And I think that can definitely enhance the physician visit through the neuromotor program as well. So we do a lot of file reviews. We can, from year to year, see 30 direct or indirect consultations or a combination of both. We do chart reviews several times a year as new referrals come in. We do regular case discussions. Sometimes we're waiting on a psych ed that was, just going to be done through the school system. We need to take a look at it. Or there's been some kind of change in status. Because of the way that we book our sessions, typically we can book a new case within just a couple of weeks after the case discussion. So it's really timely. And there are some cases that are very complex and may require more than one session. and that's quite intentional. I cannot tell you how much legwork my colleagues do to build trust with some families. It can take weeks, it can take a whole school year or two before a family is willing to open up to my colleagues and to even accept that maybe they'll have the possibility of communicating with a physician who can come to them and sit in a safe space in the school and have a confidential conversation because after all, we're there for the family and for the children. And I will pass it on to my colleagues now.
Excellent. Thank you so much, Dr. Glodjo. So my name is Marie DesRosiers, and I'm one of the occupational therapists on the team, and I've been working on this program for over 20 years. So it's a very passion of mine, this community work. So I'll start with a brief overview of who we are and how our program is structured.
Next slide.
So the Children's Services Resource Team, or CSRT, is made of 2 full-time physiotherapists and 2.7 FTE occupational therapists. We are all employed by Fraser Health. Our program is jointly funded through the contract with the Burnaby School Board and MCFD. So the Burnaby School Board is funding supports our role within the school system, helping children with special needs from kindergarten to grade 12 to attend school safely and to enhance participation. The MCFD funding supports our work with families, focusing on helping them safely care for their child at home. And we help those families to acquire special equipment that they need for safely care for their children at home. It is important to notice that we are not funded in Burnaby to provide services to private or independent schools. And we are not funded to train private caregiver in the home. It is the parent's responsibility to train outside caregivers. Referral to CSRT, they can come from several sources, including the school district, which is the majority of the referral we received, BC Center for Ability, when the child transitioned from preschool to kindergarten, physician, parents, and MCFD can also refer, thinking here more about social worker. And in terms of our eligibility, CSRT serves children with a moderate to severe developmental disability where there is a physical safety concern, a child with physical disability requiring assistance, and or a child with complex medical needs that require hands-on support and training of the educational assistant in the school system so the child can safely attend. Now, Debra will talk about the 2 stream of our program. Next slide.
Okay, next slide, yeah. Thank you, Marie. My name is Debra Pearson, and I'm one of the OTs on the team. There are essentially 2 streams of service that we provide through CSRT. The majority of our clients are those students with physical and or developmental disabilities, and they will usually remain on our caseload throughout all of their schooling years. This other branch of service is the one-time motor assessment or consultation that we do in the school system. These referrals are sent in for students who are struggling at school, but they do not have a diagnosis. So the school works in conjunction with the family, noticing some finer gross motor concerns, and they make a referral to us because of how these motor concerns affect their school participation. So often the referrals will look like the child has difficulties with written output or falls off their chair. We're concerned for their safety, their coordination issues noted in gym class. Those are the kind of referrals we get on this one-time motor assessment consultation stream. So we will screen these referrals once a month, and if they qualify for a consultation, we'll put their name on our wait list. And we're happy to say we have managed to decrease the waitlist times now from 18 months down to 12 months now. Next slide. So a little bit more in depth about our caseload students. When we're talking about our caseload students, we're talking about those that require equipment and supports to attend school safely. So those are the students with Angelman syndrome, DMD, Rett's, Down syndrome, CP, etc. So as Marie said, before their kindergarten entry, the Center for Ability will often send in a referral, and we will be in the transition meetings with the school prior to kindergarten. We'll meet the family and the students in the summer and work on ensuring all the equipment is in place for September. So we were looking at potential need for a mechanical lift, slings, a bathroom with a change table or toileting equipment, specialized seating, maybe wheelchair desks, even access to the school like ramps. At the start of each school year, we will train the EAs on how to care for the student safely. So how do you transfer the student, feed the student, the toileting routine? The physios are working on mobility, gait training. We look at splints, AFOs. Once the physical safety needs have been addressed, we therapists shift our focus to consulting on inclusion and access to the curriculum throughout the school year. Training is completed every year, or if there's a change in the student's condition or a change in EA staffing. And EAs can change, staffing can change quite a bit throughout the school year, requiring more training. In the home setting, we assist families to obtain equipment such as hospital beds, lifts, mattresses, bathing equipment, and we show the family how to use the equipment safely. And if, like Armansa said, if the student requires medical follow-up, we will liaise with the family, we can liaise with her and with various clinics at Children's Hospital and Sunny Hill, like specialized feeding clinics or ortho clinic or CP neuro clinic, PMT, gait lab, etc. Again, it's important to note that our mandate with SD41 and with MCFD does not cover ongoing therapy services in the school or at home. So we must make this clear to families that we are not providing therapy in the school. They can access their at-home program funding or autism funding to get their weekly therapy services out in the community. So I'll head it back to Marie now to talk about more of the consultation stream of service.
Next slide. Yeah. So our one-time consultation service is designed for students who are experiencing, as we said before, fine and gross motor difficulty that are impacting their learning or participation at school. The consultation is comprehensive and typically will include discussion with both the teacher and the parents, classroom observation, formalized assessment like a movement ABC or VMI or handwriting protocol. And then these information help us to understand how the students' motor skills are affecting their function across different school and home activities. Following the consultation, a written report with recommendation is provided to school and the family. And these recommendations are practical and school-based and may include classroom strategies, environmental adaptation, or suggestion for skill development. When assessment findings raise concern about underlying motor challenges, parents are then encouraged to share the OT report with their community pediatrician. This can help support diagnostic clarification, for example, a diagnostic of DCD, and guide for the next step in community-based services. Next slide. However, sometimes, as Dr. Glodjo mentioned, families face barriers accessing a community pediatrician. So in those cases, the CSRT therapist can consult with the DevPed on the team, and the developmental pediatrician can provide a comprehensive development assessment. So as Dr. Glodjo mentioned again, that will include a developmental interview with the family. It could be a classroom observation. The doctor also have access to the student file, which in there she can find OT report, SLP report, psychoed, and then this gathering of information allows for a more complete picture. Then the detailed report from the DevPed can be shared with the community pediatrician when one is involved, or DevPed could also refer to one. This collaboration with developmental pediatrician is critical in helping children and family connect effectively with the medical system, and it also helped to get the ministry designation, which then provide extra support in the school for the student. Another part of our role is to provide education to the school staff around strategy to support fine and gross motor functioning and development. So we hold breakout sessions during Pro-D days, and these sessions help spread knowledge across the wider school population. Now we will share 3 case studies reflecting situation where the collaboration with the developmental pediatrician was significant. Next slide.
Okay, this first case study is around a student who has been on our caseload since kindergarten and recently struggled with the transition into high school. So this is Ralph. Ralph is a 12-year-old boy with Down syndrome and autism. He is nonverbal and he presents with significant sensory issues. His family situation has evolved since kindergarten. Initially, he lived with his mother, then with both parents, and now he is living with his father. The family faces financial hardship and encounter obstacles when trying to access any community medical services. They really are in survival mode, this family, but they really do connect with the school, and the school often helps them. So when Ralph transitioned to high school, he was quite dysregulated, and his behaviors only intensified from month to month. He would remove his clothes, drop to the floor, defecate on the floor, play with his feces, and masturbate. He would typically do this in the bathroom, but was known to drop in the hallway or in the atrium. And the school staff at that point, he was new to them, they were having a hard time figuring out when he would do this to prevent it. And he was also too big in size to try to prevent him physically from going down to the ground. He would also cry out loudly. So often I'd come into the school and he would be on the ground, fully clothed, but crying and very dysregulated. So the school team found this to be quite distressing and tried a number of different strategies to help Ralph. They brought in a known EA from elementary school to work with him for a few months. They brought in behavior specialists from the district, and they tried liaising with Ralph's newest community pediatrician, but to no avail. So the school team did not know what to do and approached CSRT OT for help, as the school often looks to our team as the connection to the medical field. So the case was reviewed by DevPed, and the developmental pediatrician reviewed Ralph's medical file and noticed there were gaps in service. So the developmental pediatrician sent the fellow in who spent a good hour speaking with Ralph's father, obtaining history, observed Ralph in school, and happened to then observe him in the bathroom in this dysregulated state. So the developmental pediatrician was then able to connect with the new community pediatrician regarding what was going on at school, and Ralph was started on a new medication. This medication helped Dad get Ralph in and out of the car with ease, get him to school, and help him regulate so now he can attend school safely and respond to the learning strategies and techniques that school want to implement. Dad reported it was very helpful to meet the DevPed at school because during this hard time, he was often called to bring Ralph home halfway through the day. He was struggling to find work because he always had to be available to bring Ralph back. But he knew coming into the school that the school was compassionate and trying to support Ralph. So he felt very supported and relaxed in that environment, and he was able to get to school to meet with the DevPed. He also said at that time it was very hard to get Ralph in the car to get out to a medical professional in the community. So as it stands now, because of the DevPed interaction at school and the assistance, family have continued to follow up in the community with their medical team. Ralph is attending school on a regular basis. He's doing quite well. And so it's a really good example of how the DevPed was able to come in at that one instance and consult with us as therapists and the school to get Ralph back on track from a medical point of view. Okay, next slide. The second example is an example of a student who we saw on a one-time consultation basis. So this is our stream of a one-time service. This is Sasha, a new grade 3 student who came into the district. The school quickly noted that Sasha struggled to eat or toilet independently. She had difficulty drawing shapes, cutting with scissors, completing academic work, and they even worried about her climbing playground equipment safely. So the school put in a referral to CSRT OT, and they also drafted a detailed letter of their concerns, handed it to parents, and asked them to seek guidance from a community pediatrician. When mom was contacted by CSRT, she reports she had a Zoom call with a doctor, but Sasha was not available and Sasha wasn't on the call, and there was no follow-up recommended by that pediatrician. Mom informed CSRT that she wasn't as concerned as school. She dismissed most of the concerns, stating that she coddled Sasha at home, and that's why Sasha was having some delays. So the CSRT therapist went into school, completed a school assessment, and noted that Sasha was short in stature for her age. She had possible dysmorphic facial features. She was highly distractible and required one-to-one help to complete any task. She did not have the automatic motor memory for letter formation. Her pencil grip was poor. She had low tone. She scored below average on the Beery VMI, and she was in the 6th percentile for the total motor score on the movement ABC3. So the therapist brought Sasha's file to the DevPeds for a consultation, and mom agreed to this. The developmental pediatrician agreed to come into the school, met with mom and did an extensive medical developmental history, observed Sasha at school, and identified that Sasha had delays in several domains: fine motor, gross motor, speech, and academics. The developmental pediatrician was able to write a medical report and diagnose Sasha with a complex neurodevelopmental disorder related to prematurity with probable genetic difference. Having this paper with this diagnosis was very important because it helped the school psychologist review the file and assign Sasha with a Ministry D designation. This gave the school funding, which helped provide EA support, which could then be a consistent person to help Sasha throughout the day while she's out in the community now doing more diagnostic assessments. So medical referrals were made, and Sasha is doing well with consistent EA support and with a structured routine and environment. The CDBC assessment is still pending, and we at CSRT have finished our report and closed the file. So Marie will now finish with one more case example. Next slide, please.
So in this last case, the collaboration with the DevPed allowed a newcomer to get connected with the needed medical support and accelerated their school entry. So Dana arrived in Canada in the fall of 2022 as a permanent resident with her family, with only one medical documentation from Korea indicating spasticity and intellectual disability. At the time of arrival, the family has no connection to any physician or were not under any government program. Parents showed up at the school to register their daughter, who was non-weight bearing and was sitting on an umbrella stroller. The school noticed that there was definitely some physical difficulty there. And father reported that Dana was just carried up the plane to come to Canada, so they didn't come with any other equipment. So the school sent a referral to CSRT for an assessment. During the intake process, the CSRT OT brought in the developmental pediatrician for a home visit as CP was suspected. So the doctor completed the medical review, did an observation and some assessment, and then Dana was then diagnosed with cerebral palsy, GMFCF level 4. So she was then referred to multiple services, including a community pediatrician, orthopedics, ophthalmology, dental services, neuromuscular program, and the seating team, as she needed a wheelchair. So this collaboration enabled a timely access to medical follow-up for this student, which in turn provide the medical foundation needed for us therapists to begin equipment prescription for this student. Dana was accepted on the at-home program, and by the winter of 2023, she was able to safely start school. So those three cases demonstrate for us and that CSRT and developmental pediatrics work together to really bridge the gaps in care and support families navigating complex medical system. We believe that this type of collaboration is essential for equity, access, and timely intervention for our most complex student. Dr. Glodjo will now talk about some of the anticipated challenge of this collaboration.
Thank you so much. Um, my colleagues don't give themselves enough credit for how much incredible legwork they do, along with their colleagues, to get to the point where a DevPed is even involved, because they have to hold the entire responsibility of case management. That is receipt of intake, gathering consents, gathering data, confirming availability with parents. If an interpreter is needed, one can be arranged through Fraser Health, but it is a set of steps that they are doing while juggling their caseload and their uh, um, wait list, which is a huge undertaking. And therefore, that planning, that discussion and that planning and breaking things down into what is important and how to prioritize is essential so that everyone's time is optimally used. And these are not cohesive timelines. These are things that have to occur over time, but they are wizards at being able to get things together in a way that can be predictable for my schedule and that of my colleagues who attend that clinic with me. Um, Also identifying the need for multiple and serial visits if needed. Aligning with the school calendar means that there are many missed opportunities for being able to engage with kids. We have workarounds during spring break. There may be things that can occur, such as interviews with parents that happen over the phone or via virtual health while school is not in session. So we try many different creative ways to not have a lot of time lost. But kids are kids. Sometimes they're sick. Sometimes a parent or a caregiver cannot get time off work. Things fall apart, and we have to try again. Despite being involved in this longstanding service, institutional memory is only as good as the people who are in it. So, if staff are changing within a given school administration, the knowledge can drop off, and their awareness of CSRT and the services which they provide can sometimes reduce in a school that was otherwise in regular contact with CSRT. So this is something that we see in the district. Some schools we hardly ever hear from, others they call on us frequently. Despite there being an annual memo that is circulated to all of the administrators, sometimes we just don't hear back from certain schools that probably do need support. So what's important is to value the relationships and to value the partnerships, which we have every time we have a school visit and that face-to-face contact. Um, the leap forward with those relationships is significant, and the school feels more comfortable with reaching out again. And I think that is really, really important. Um, there's a trust that's built. There's a partnership um, that I think enables them to think about the other children in their school and the ones that maybe they haven't brought forward to CSRT through a referral. Um, I would say that the highlight of my week is working with my team, and the highlight of my week especially is when I have a pediatrician who's training in developmental pediatrics who is able to attend in their first year and really take in the landscape of being back in school, wearing a different hat than being a student, and then coming into their own as independent consultants in their senior rotation experience. Um, we are always striving for advocacy, for equitable access to developmental care for all families, especially those that are already marginalized and difficult um, to reach under more traditional medical models where the onus is put on the family to go and jump through many, many hoops. Um, and by being involved in looking at the files and doing the triage, um, having those open dialogues with newer therapy staff in CSRT can also enhance their skills and confidence about knowing when to perhaps get a dev feed involved. So in closing, leaving a few minutes for questions, this very important partnership does enhance developmental care of school-aged children, Burnaby being one very lucky school district where the service is available. It can bridge big gaps between health and education and also increase knowledge base within our therapy teams, knowledge base within our schools, and also in our developmental pediatricians who are training to be independent consultants and themselves advocates. So again, we hope that we are one small example of how a bridge can exist between large chasms out there. And we hope to continue to celebrate this work and proceed on. Thank you so much, everyone.